My name is Dr. Hu, and I'm a resident at Penn State Hershey. I'll be presenting our experience with peroral endoscopic pyloromyotomy for gastroparesis in a patient with a history of sleeve gastrectomy. Our disclosures are listed here. I personally have no disclosures, but it's up for 7 seconds. Gastroparesis is defined as delayed gastric emptying in the absence of mechanical gastric outlet obstruction. The overall prevalence is 2.4 per 100,000 cases, and this condition can cause significant decreases in quality of life. The gastroparesis cardinal symptom index is an instrument for measuring symptom severity. Patients rate their symptoms from a scale of 0 to 5, with 5 meaning very severe. The GCSI includes 9 different symptoms related to nausea, vomiting, fullness, early satiety, bloating, and distension. You can see the chart listed here. It can also be used to monitor outcomes after treatment. There are various treatment modalities for medically refractory gastroparesis, including peroral endoscopic pyloromyotomy. This is an adaptation of peroral endoscopic myotomy, also called POEM, which was developed for treatment of achalasia. The POP procedure includes an endoscopic submucosal tunneling technique to divide the circular muscle fibers of the pylorus. Success rates have been quoted upward of 90% with comparable efficacy to laparoscopic pyloroplasty. Although the POP procedure has proven beneficial in patients with normal gastric anatomy, it remained unclear if the benefits of peroral endoscopic pyloromyotomy can be extrapolated to patients with altered upper gastrointestinal anatomy, such as after bariatric surgery. There is a dearth of literature in this area with only case reports to date. So in our video, we describe our success with peroral endoscopic pyloromyotomy in a patient with a prior history of sleeve gastrectomy. Our patient is a 61-year-old female who presented with persistent reflux-type symptoms after undergoing sleeve gastrectomy and paraesophageal hernia repair 2 years prior to presentation. Her initial GCSI score was 29, which is very high, with points for nausea, stomach fullness, inability to ingest a normal-sized meal, bloating, loss of appetite, and a visibly larger abdomen. Her radiographic workup consisted of an upper GI swallow study, which showed normal esophageal motility without any stricture or dilation. The gastric sleeve was noted to be dilated with a maximal distension of 16.7 by 8.9 centimeters after ingestion of egg salad. She subsequently had a gastric emptying study which demonstrated delayed gastric emptying with only 71% emptying at 4 hours. She was considered for conversion to gastric bypass, but was referred to our endoscopic surgery service after she expressed concerns regarding exacerbation of her dysphagia. So she was consented for an endoscopic pyloromyotomy. A location on the lesser curve, approximately 2 to 3 centimeters away from the pylorus, was selected to create the submucosal bleb. This was a fairly difficult angle to access, secondary to the sleeve anatomy, due to the lack of space to maneuver around. We were able to get an adequate bleb, and we were able to inject a mixture of saline and methylene blue. The mucosotomy was then performed using a triangle tip knife large enough to accommodate the endoscopic cap. Care must be taken to prevent early bleeding or muscular injury at this point. So as you can see, we're just using the triangle knife to make that mucosotomy. The dissection through the submucosal tunnel was then carried down to the level of the pylorus, and although not shown here, there was some branching vessels that were controlled, one which required extra cautery to control the bleeding. The angle of dissection from the sleeve gastrectomy was not ideal for a complete myotomy, so after we exposed the pylorus, we proceeded with partial myotomy. Care was taken to not enter the duodenal mucosa. The partial myotomy was sufficient for this case, and after this, the gastroscope was easily advanced into the duodenum, whereas previously we had difficulty advancing the scope past the pylorus. The mucosotomy was then closed with serial firings of 5 through the scope clips until we achieved hemostatic closure, and then the carbon dioxide was evacuated and the scope was withdrawn. So here you can see us placing that clip, and there's a total of 5 over there. So at 1 month follow-up, her GCSI improved from 29 to 9. She was continued on a PPI and sucralfate for 6 weeks post-procedure and was advised to continue to follow a gastroparesis diet consisting of low-fat, low-fiber, small, frequent meals. She now only follows on a as-needed basis. So this case illustrates a few key points. So the POP procedure can benefit patients with gastroparesis in the setting of altered upper gastrointestinal anatomy. although the sleeve anatomy did add an extra level of difficulty to the procedure was effective in reducing her gastroparesis symptoms. Given the current limited literature on the POP procedure in this particular patient population, more studies are necessary to establish the safety and efficacy of this procedure before its implementation as standard practice in the management of gastroparesis in patients with altered anatomy, such as bariatric patients with prior sleeve gastrectomies. And that's all. Thank you.